Let us move on to the next lecture by British Association of Urological Surgeons, and the topic is going to be using national workforce data to improve the access to urological care. I kindly invite the moderators to introduce the relevant speaker.
It's my singular honor to introduce Professor Ian Pearce. He is a consultant urological surgeon and andrologist in Manchester, and he is currently the president of the British Association of Urological Surgeons. We are very honored. President himself is here to deliver the BAUS Lecture at the 25th anniversary annual academic sessions of Sri Lanka Urology Association. Over to you, Ian.
Good morning, everyone. Thank you, Kalana and Manjula. Thank you very much for inviting me today. It's a real privilege and a real pleasure to be back in Sri Lanka, and I'm very delighted to be able to participate in this momentous occasion on the 25th anniversary of SLAUS. So I'm really very, very pleased to be here. I'm going to talk to you this morning a bit about the work that we've been doing in the UK, in Britain, in terms of using our national workforce data to try and improve patients' access to urological care. The credit for collecting all of our workforce report goes to these two people. This is Judith and Steve Payne, who's my ex-senior colleague. He's currently in Africa operating. And every year, we collate a workforce report. It normally comes out a couple of weeks before our annual meeting in June, and it looks at the previous calendar year. So the most recent report we have is of 2023. And this all forms part of our strategic aim, one of the three main strategic aims that BAUS has for the next sort of 3 to 4 years. And we're approximately halfway through that. And that is really to use our expertise to try and ensure equitable access for urological care to all of our patients across the British Isles. So what does that journey look like? Well, the first thing to think about is this. This is Albert Einstein, of course, who everyone will recognize instantly. And he was very fond of saying that he was given an hour to save the world. He spent the first 59 minutes figuring out what the problem was. I know that we'd probably argue it doesn't need 59 minutes to figure out what's wrong with the world, but this was a long time ago, of course. So 59 minutes figuring out what the problem might be, and a minute to solve it. So this is no difference in terms of workforce. So the first thing we have to think about is, what is the population that we serve? And whilst I don't expect you to sort of memorize any of these figures, this just shows the population in each of the BAUS regions within the UK. This is by million, of course. We also have this data looking at deprivation, because, of course, not every patient is equal in their needs, clearly. There are areas of greater deprivation than others, and we can use this data to give an adjusted population figure. I haven't quite got a pointer, but the area that I work in is that dark blue area at the top left. That's the most deprived area. We also have data regarding our workforce in terms of the number of urology units in each region and the average number of urological consultants per unit. So we've got a good, accurate picture of what our consultant workforce looks like in terms of geographical distribution. What then about equity of access? So we can correlate the figures in terms of our consultant workforce and our population, which is adjusted for deprivation, and we can show then the consultants per head of population. And again, you may not be able to see the finer figures, but essentially between the top and the bottom, with East Midlands and London, in terms of the number of people serving the population, there's a 41% difference. Now, we don't have to be statistical geniuses to know that 41% difference means that we do not have equity of access to urological care across the UK. So we're on the verge then of knowing what our problem might be. This is Lord Kelvin, who you may not recognise, but he would have been 200 years old today. Well, not today, but this year. So he is also celebrating an auspicious anniversary. And he was fond of saying that if you can't measure something, you can't improve it. So again, it's all about really trying to find out exactly what we're looking at. And there'll be lots of people in the room thinking, well, it isn't just the consultants who are delivering service, and that's absolutely right. We have got the same figures for every different branch of our workforce, whether it is trainees, allied health professionals, and our non-consultant grade doctors. So we have all of that data, and we can amalgamate all of that to figure out how easy it is to access our care. What about subspecialist interest? This is, I was talking earlier, just as we were waiting to put our slides up, and we were talking about our apology slide. This is my apology slide. It's got far too much data on for anyone to look at, but it's just to illustrate the level, the granularity of the data that we've got in terms of each region and each consultant's declared specialist interest. So how does this help us? Well, there are three different colours here. The blue colour, they're the consultants. Okay, this is their specialist interest. The orange bar represents our current batch of trainees, what they wish to do in the future. And then next to that, they're the green bar. That's the consultant body, their specialist interest, for those people who are over 55 years old. We know in the UK that the average age of retirement for a urologist is between 61 and 62 years. So in other words, the green bar represents those people who are likely to retire in the next cohort of training. What we can then do is map against the people coming up, against the people dropping off the end. So endourology, it appears that we're pretty stable, aren't we? Maybe we've got it right, maybe we haven't. It depends on other things, which I'll talk about in just a second. But it looks like we are replacing people who leave. If we look at andrology, on the other hand, more and more people want to do andrology than we currently have looking to retire in the next sort of training scheme duration. That may not be a bad thing, depending on, again, the need and the backlog, etc. So it just goes to show where we are. This is Franklin Roosevelt. This is his unfinished portrait, a very famous portrait. He was having this painted when he had a stroke and died at early part of his 4th term. And really, we're also halfway finished. We need to think about specialty level. We need to think about the volume of work that gets done. And interestingly, we also need to think about the backlog, particularly from the pandemic. In the UK, the biggest backlog from the pandemic in urology is core urology, in particular things like circumcision, hydrocele repairs, and also andrology. So we need all of that data to think to ourselves, what is the demand? What is the deprivation? What is the current backlog? And what is the body of professionals delivering that care? So we still have quite a long way to go. But we're certainly past the starting point. We're certainly on the way. We've perhaps used up maybe 30 of Einstein's 59 minutes, so we're definitely on the way. How does this help us? Well, if we can look carefully, we should be able to predict subspecialty shortfalls. We should be able to take trainees at the very beginning of their career and say to them, this is likely where the jobs are going to be in terms of geography and in terms of subspecialty interest. So that helps us guide our colleagues. But it also helps us look towards government, towards lobbying for training. So we've got the data to show that if we're expanding our training scheme in the UK or expanding our workforce, we know where it should go and we know what it should be doing. So that gives us increasing power in terms of influencing decisions, with the ultimate goal, of course, of creating equity of access to our urological care within the country. Thank you very much indeed. Real pleasure to be here. Thank you.
Ian, you should stay on the stage itself. So on behalf of SLAUS, we thank you very much for that wonderful lecture and hope to listen to you in the subsequent presentations as well. As a token of appreciation, we have a presentation. You could come forwards to the center of the stage.